This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Okay. Okay, thanks everyone. So we're doing pretty well today. Only a few minutes behind time, which is great. So we're at the last session. It's been a great day so far, so thanks everybody. So it gives me great pleasure to invite Justin Denham as our next speaker. So Justin's the Medical Director for the Victorian TB Service, been on MTAC. Justin's got an interesting background. I didn't say in his bio, but he's got a Master's of Bioethics. I know he's on the Ethics Committee for the Union for TB, which is an interesting angle as well. So I'm sure he can talk about lots of different broad topics. But today he's going to talk about latent TB, which is Justin's very well known in Australia if he's interested in this. So thanks, Justin.
Thanks, Andrew. So I think, Andrew, when you gave me the title of this topic, I don't think you realize how controversial it might be. So I've spent, just on the title itself, I've spent probably an inordinate amount of time thinking about the word therapeutic. Because to me, therapeutic implies a treatment to heal from a disease. You know, it implies that there's a problem there that we're going to intervene and give some therapy to fix. And it's not always clear to me, and certainly it's not always clear to many of my patients, that they have a disease that needs to be fixed when we're talking about latent TB. We can have interesting intellectual conversations about incipient TB and circulating microRNA and PET scan results, but the reality is that when those of us who are clinicians sit with patients, they don't feel sick. And that really changes the dynamic of how we think about what a therapeutic option for latent TB might be. There are some people who this will be pretty non-controversial for. You know, if Ben is seeing a 2-year-old child who has very close contact with a smear-positive case of TB, or a young child who's got a recent conversion, these are non-controversial opportunities for us to intervene and give some effective therapy to prevent progression into active disease. But there is a significant spectrum, and so when we come to thinking about what therapeutic options for latent TB exist in Australia right now, we need to take a big step back and think about who is it that we're actually talking about, and who might those therapeutic options be applied to, because that gives us perspective on the kinds of questions we need to ask to decide what an appropriate therapy is in a given situation. So I'm going to go right back to thinking about who are we actually talking about in Australia. Now, in Australia, we sometimes start by, in this area, by thinking about the fact that give or take 90% of people who develop active disease in Australia were born in another country, generally in a high-incidence TB setting. And about half of the remaining 10% are household contacts of the first 90%. And so it certainly is, from a public health perspective, a large predominance of active TB cases whose narrative history of how it is that they come to be in Australia with active TB is a migration-associated one. It is one where they have acquired latent TB at some point in the past and migrated to Australia and later reactivated. That is the common pathway for most of what we're talking about from a public health point of view. And that makes sense. We can see in the most recent census, or at least the most recent census that has been accurately collected, we're still yet to see how the last one's gone, more than 1 in 4 Australians were born overseas. And if we break that down a little bit, with some nice work that Katie Dale has done over the last few years, we see also that the proportions of Australians born overseas coming from higher TB incidence settings has also steadily increased. So a large number of people whose personal histories may be more likely to include TB exposure. Now, we were interested in, first of all, trying to work out what proportion what proportion of the Australian population may have latent TB and how they might be distributed, to start to think about this question. And a few years ago, we got one tool that we could start to use for that, with some work that Ryan Hubin and Pete Dodd led, looking at what's called the annual risk of TB infection. So essentially, they looked at all of the available data they could find about the likelihood that people living in different parts of the world would have acquired TB infection by certain ages. And use that over time to create a new global estimate of how many people right now were thought to have latent TB around the world. They came up with this figure, which has been widely circulated, of just under 1 in 4. We decided that, given that we had so much data from the census here in Australia around country of origin and people's pathways to migration to Australia, we could use some of these international estimates to look at the Australian setting and think about who might have latent TB here and how they might be distributed. So to give you some idea about how this works, we start with census data, and I'll talk about the 2016 census, and then we can look at some trends in a minute. We have all of the data that you would expect from the census. This is individual level data, and it is anonymized. So let me illustrate it with an anonymous individual that we take from the 2016 census. Now we know that this particular individual was born in Canada in 1979 and lived in Canada for 10 years before migrating to Australia. Okay? And so what we do is we take the country-specific estimates for TB acquisition per year in Canada. We apply those for the 10 years that that person was resident there. We know that they migrated to Australia in 1989, and so beyond that time until the present, we apply an Australian-specific indication. By the way, the Australians in the audience should be very worried about the fact that that comes up in Google Images when you say image of Australia. The last time I gave this talk, it was a picture of Barnaby Joyce, but I've had to change that, obviously. So anyway, then we take that person, we walk them through their cumulative risk of having acquired latent TB up until the time of the 2016 census. And so over that period of time, we can see an estimate of how likely it is that this person has latent TB at that point. We then repeat that process, give or take 23 million times, and come up with some very specific individual-based estimates for latent TB prevalence. And cutting to the chase, this is what Katie and the group of people who worked on this found. I'll just highlight a couple of numbers from this. First of all, this is analyses that have been done on the 2006 and 2011 and 2016 census. So we've got some trend over time here as well, too. And in 2016, we found that there were an estimated 1.1 million people resident in Australia who had latent TB. And about 1 million of those were overseas born. Okay? If we think about, and the total numbers of people had been steadily increasing over this period of time. Okay? If we think about proportions, less of a change, because what we found was that while the proportion of individuals born overseas had been increasing between these groups, between these 3 census years, their proportionate risk of having been infected with latent TB had been falling. Reflective of a number of things. Some of those are demographic, some of them are about control of TB in some of our high migration countries. But overall, a little over 5% of all Australians estimated to have latent TB, but about 17% of Australians who'd been born overseas who had latent TB. Now, because we've got census data, we can then do a number of other things with that. Here in Victoria, we've been interested in thinking about how that maps spatially. And that's been helpful for us, just as one example, thinking about how in some of the northern parts of our states, we've seen steady increases over this decade in the proportion of people estimated to have latent TB. That's something that we're currently using to be thinking about the future burden of active disease and the kind of resourcing that we need to provide to get out ahead of that. And those are trends that we're already starting to see reflected. The big picture, though, is that as you'd expect, based on migration patterns, it is metropolitan areas in Melbourne which have the highest proportion of people with latent TB. And we can, again, for service planning reasons, break that down to think about the sorts of resources we need to provide and the sorts of places that are most likely to need interventions around latent TB. Okay. So, if we take that question broadly, The biggest question we might ask is, what sort of therapeutic options do we want for up to 1.1 million Australians? It's an enormous population of asymptomatic people, and if we're starting to think about therapeutic options for latent TB, this is one end of the spectrum of that question. So how do we come at that? Well, the first thing to say is that all of our treatments for latent TB will have some assessment necessary about the benefits and the impacts or the risks. Okay? In terms of the sort of benefits that we might think of, when we talk about treating latent TB, we're really talking about preventing future active TB disease and everything that comes with it. So the benefits, of course, to the individual will include less likelihood of getting active disease, from a public health point of view, but also from a broader psychosocial point of view. There are benefits in terms of subsequent transmission pressures that happen when we reduce cases of active disease. And there is, I think, a not negligible psychological value that comes from people's confidence about how likely they themselves are to be at risk of active disease in the future. So I think that comes into it. On the risk side of things, we're often talking about a duration of therapy, about how much burden treatments put on individuals, and about how likely people are to get side effects. But we also have a range of other factors, including cost, whether to individuals or the healthcare systems, and also issues around the diagnosis and treatment of latent TB, which does include stigma. People sometimes, I think, forget about we talk about the stigma associated with active disease in many communities and cultures, but active and latent disease are not necessarily separated all that well. And I know that I certainly have had a number of people, and I'm sure you have too, who have experienced significant worry and concerns about stigma associated with latent TB diagnosis and treatment. And so these are all factors that need to be weighed up in thinking about what an appropriate therapeutic option for a particular individual or context might be. Sometimes that is relatively straightforward. We might have a situation where you can identify a person who is at very low risk of getting disease in future. We might have some treatments that are not very effective, have high risk of side effects. Clearly, these things will tip our balance towards not using the treatments at all or in this particular situation. On the other hand, if we have individuals who we can identify who are at very high risk of progression, they will have a lot of benefit that accrue from treatment, and the more effective and well-tolerated our treatments can be, the easier it makes it to say that, of course, we should give some treatment. So overall, in terms of that group of people that we're talking about, how high is the risk of progression to active disease? So to generate this figure, this is taken from, again, some of the work that Katie and others have done, which starts from the graphs that I showed you before, estimating who has latent TB infection. So when I say here, how high is the risk of progression to active disease, a couple of caveats are important. The first is that all of these are about actual notification rates for TB here in Australia, but the denominator on which they are based are estimates of people with latent TB in incoming migrant cohorts. So, for example, if we look at how likely people who were born in India are to get TB in Australia, we can look at actual notification numbers. We can then go back and look at all of the incoming migrant cohorts and how many years since arrival they are distinct from, they are separated from the time at which they are notified with active disease. And in this case, we've also then applied our estimate, which says that, for example, 25% of that incoming cohort, broken down by age and sex, are to have latent TB. And so when you look at the absolute numbers here, we're talking about, in the first year or two, 500 per 100,000 as far as an absolute risk of going on to develop active TB may be, in this sort of ballpark, okay? Which is much higher than the numbers that we typically think of in Australia, because again, we're estimating based on the people who we think actually have latent TB at the time of migration, rather than the whole cohort. I think that's really important because it helps us to shift to thinking about what the actual absolute risk is for an individual who's sitting in front of us with a positive test for latent TB. We can see that that risk is, as we intuitively know, much higher early after arrival, presumably reflecting mainly time from acquisition of most recent TB infection, that it falls off over time, but half of all TB disease is still occurring more than 5 years after arrival. And so while it doesn't show up so well on this graph because of how high the early risks are, even out here in the group of people who've been resident in Australia more than 40 years, we're still talking about rates in the order of 50 per 100,000. So still considerably above background rates in Australia. Now we know that some subgroups are at substantially higher risk. We know that if we have somebody with latent tuberculosis who's a recently acquired infection, who has poorly controlled HIV or going on to a TNF-alpha inhibitor, we know that these groups are at high enough increased risk that it's pretty non-controversial in all of our recommendations to go on and treat. We also know that there's a penumbra of people who we recognize are at higher risk, but there's still some controversy about just how much risk there is there. The fact that I think it's reasonably well established now that smoking and diabetes will increase your risk of latent TB reactivation by something between 2- and 3-fold may be really important in some people, but may not be a strong enough risk factor for us to say everybody who smokes or everybody with diabetes should be treated. But this gives us some perspective in terms of absolute risk, and so when we come to the actual treatments and thinking how effective they are, that gives us a baseline from which to start. So, how good are treatments? We are probably all familiar with some of the older treatments that have been used for a long time, so isoniazid being the archetype here. And if we go back to some of the earlier large trials, such as the International Union trial, which ran through the late 60s and 70s, in this study, participants were randomized to receive a number of regimens from placebo through to a year's worth of isoniazid. And about 28,000 people were randomized here, showing quite convincingly reduction in TB incidence over this period of time that was connected with the duration of isoniazid therapy that was given. Now, subsequent reanalyses of these trials were very influential. And so while, if we look here at people who get beyond 12 months, 18 months, out to 24 months worth of treatment in these and other studies, we see a plateauing of benefit. And so a judgment was made that as longer courses of isoniazid were more associated with hepatotoxic reactions, with a plateauing of the additional benefit, 9 months was thought to represent an appropriate balance between long enough therapy to get an appropriate benefit without the escalating risk of hepatotoxicity. And that's important because essentially all of the major studies that we've had since that time have been compared with isoniazid. Typically with 9 months of isoniazid with a few additional examples. So in more recent times, we have seen 9 months of isoniazid versus isoniazid and rifampicin studies of 3 and 4 months, primarily in children, although one small study in adults as well. We have seen weekly rifapentine and isoniazid compared with 9 months of isoniazid alone, and then we've seen 4 months of rifampicin. And so all of these studies have been ones that have used non-inferiority methodology and have ultimately concluded that each of these regimens is non-inferior and not superior to 9 months of isoniazid. Okay. And that's reflected in what is currently the WHO treatment guidelines, which suggests that isoniazid of a course between 6 to 9 months, daily rifampicin for 3 to 4 months, or some of these rifapentine-based therapies can all be used interchangeably. They do, none of these treatments, though, have themselves been compared with placebo. And so there have been a number of attempts more recently to try to reanalyze not just the relative effectiveness of these treatments, but some of the absolute benefits that they bring. One of those, just at the moment, is a nice, large individual patient meta-analysis that Leo Martinez at Stanford has been leading, which I think very helpfully, and I know a number of people in the room are involved in this study, but has shown in 140,000 close contacts under the age of 18, a more than 90% reduction in incident TB risk after contact in those children at highest risk of progression. So certainly showing high absolute benefit of giving these treatments to the groups of people who need them the most. So given that we have a range of therapies that seem to work well in the right contexts and all are pretty well comparable in terms of their efficacy, the questions now become, how short can we get? Can we reduce the burden of these treatments? Can we particularly shorten the amount of time that it takes people and the pill burden of taking them? And so in the last couple of years, we have seen, particularly in HIV and latent TB, 1 month of rifapentine plus isoniazid. Currently, a little problematic for us here, not so much in my view because of the issue of HIV in this study. I don't see any reason to think that's a relevant factor in terms of taking these results into a non-HIV positive population. But just from a pill burden point of view at the moment, both because we're limited in terms of our access to rifapentine, but also the doses involved here currently translate into 16 tablets a day for a month, which is a pretty considerable pill burden for anybody. So until we have the opportunity to get some combination therapies, I think that while shorter, these are not necessarily less burdensome regimens. I had a quick look before today just to bring myself up to speed on some of the trials that are currently enrolling and again looking at treatment shortening. We have currently enrolling 2 months of double dose rifampicin versus 4R, which is operating out of Canada. There is further attempts to use daily rifapentine to shorten even more, and so this is 6 weeks of daily rifapentine alone versus the 3-month weekly therapy in HIV-negative participants. And I was also very interested to see, because I've often said that I think 2 weeks is a bit of a game-changing mark. I think, if we can make treatments shorter than 2 weeks, that really does change the situation. So I was fascinated to see in the clinical trials registration that there is this 2-week therapy of daily nadidium rese, which I had to look up. You probably know all about it, and you know all about this nutraceutical, which is currently not subject to regulatory approval because it's a probiotic. So I was delighted to see that we'll obviously soon have a very effective therapy that we can stop all of our isoniazid and rifampicin-based treatments coming along. One large area here that we haven't talked about, we've talked a bit about MDR-TB over the course of the morning, and all of the treatments that I've talked about so far, possibly with the probiotic exception, are really not things that we expect to see be effective in strains of latent TB which have resistance to rifampicin and isoniazid. And so it's been long practice in many centres, including here in Australia, to be recognizing the fact that contacts of MDR-TB are at extremely high risk of a disease that has very high morbidity and mortality, and so even in the absence of good evidence, we've pressed ahead with using typically fluoroquinolone-based therapy. And then over the last 10 or 15 years, there have been a number of retrospective studies, and now a meta-analysis of those studies suggesting that that is likely to be effective, and so we continue with that in practice. However, as Suzanne alluded to before, there's critically important trials like VQuIN, which are currently underway to try to first establish the effectiveness and the magnitude of effectiveness in a randomized control trial setting, and to give us prospective data on the impact of this and lots of associated things. So it's great that you were able to tell us a little bit more about some of the pharmacokinetic work there too. I'll mention too the Phoenix MDR trial, which I believe has not yet started recruiting, but is based in high MDR, XDR, TB settings and looking to randomize to delaminid versus isoniazid, recognizing that even many contacts of MDR TB, when they go on to develop active disease, may well have been infected with multiple strains, and so isoniazid may provide some protective benefit in terms of progression to active disease overall, even if it's not effective for MDR. So a few things that we're likely to see over the next couple of years, but Vequin particularly in the next 2 years we'll expect to see results from. One last thing that I just wanted to touch on was this question of post-exposure vaccines, because in some way I sometimes say to my patients that latent TB therapy is like the most complicated vaccine you'll ever have. You know, you are well now, we're trying to do something to keep you well. It's just that this vaccine involves taking a tablet every day for 6 months, which is mildly inconvenient. But a vaccine, if we could give a post-exposure vaccine with equivalent efficacy, that's kind of the end result of these treatment shortening trials. If we could get something that we could give to people post-exposure rather than these long antimicrobial-based therapies, that would have a lot of advantages. And it's been encouraging in the last year to see some potential candidates here. So I won't go into the details of this study that was in the New England Journal last year, except to say that in HIV-negative individuals living in a high transmission setting who were already positive on testing for latent TB at baseline, vaccine was safe and did demonstrate a vaccine efficacy of nearly 50% in terms of reduction of progression to active disease. Okay. So what do we make of this? Well, the first thing is that that's shown effectiveness, and that's quite exciting in the field. We don't have comparative data on what this might do, what this might look like in relation to other vaccines like BCG, but we can see that it has demonstrated some efficacy, and certainly when we think about this in terms of latent TB therapy, that's much less problematic by having a 2-dose schedule versus a long course of antimicrobials. However, 50% is considerably less effective than we know our other treatments for latent TB are. And so even though we would expect this vaccine or other vaccines to be effective against both drug-sensitive and drug-resistant strains, this has still got a long way to go before we think of these sorts of strategies being anywhere near prime time. But I think it's good to keep our eyes on the prize there, even if this is not going to change anyone's approach to contact management in the near future. So, bringing a couple of these things together, how I see this is this. Right now, we have existing treatments that we know work quite well. We have a lot of data to show that they are safe and effective for appropriately selected people at risk. And appropriately selected is the key. We need to be thinking about individual people and how we tailor the kinds of treatments that we offer and the kinds of situations in which we offer them to make sure that we are providing appropriate benefits to people who are undergoing latent TB therapy. The field needs to continue and is continuing on towards shorter and shorter treatments, again looking for things that have the least burden. That's obviously important, but when we think about the large number of people who have latent TB, you can see how critical it becomes to have the least burdensome treatments possible if we want to think about providing a treatment that is of genuine benefit to the individuals living in our community. There is a lot of ongoing work to try to best establish what therapies we can use when our first-line latent TB treatments are not appropriate, either because of drug resistance or intolerance. And where I want to finish is by reminding you that we're talking about therapeutic options here. And one of the therapeutic options that we have is to not treat. We need to make an appropriate assessment of individuals and groups and think about what we can do to both demonstrate and predict the absolute risk that they're at and offer treatments and even diagnostics that are consummate with the level of risk that we know people are at. It also means that not treating doesn't mean doing nothing. It doesn't mean ignoring this problem, because there are many things that we can do, both at a societal level and in terms of individual patient management, to help ensure both that they are at less risk of getting TB, and that if they do get TB, they are as unlikely as possible to suffer adverse consequences there. And so all of these things, smoking and diabetes and structural reform around genuine universal health care, these are critical interventions in terms of eliminating not just TB as a disease, but the pain and suffering which is associated with it. So I'm going to stop there, but happy to take any questions that you might have.
Thanks so much, Justin.
Yeah. So the question, if the microphone didn't pick it up, was about isoniazid toxicity absolutely increasing with age, but rifampicin, I think it's pretty clear from the trials and from the reanalysis that while there is a risk of hepatotoxicity and serious reaction, it's really flat with age. And so there isn't actually, there is good evidence that that risk does not increase in the elderly. So I think age does still come into it, because we know your absolute risk of reactivation changes with age, and so it will be part of it. But I think that we're in a position now to be offering effective treatment to people who are much older than the traditional cutoffs that we might have used with isoniazid. Absolutely, I think we should be factoring this in. You know, my own clinical practice is now favouring 4 months of rifampicin as the first-line option, although I also do a lot of work in general practice settings where the emphasis there is still on selecting higher-risk younger individuals who are appropriate for isoniazid therapy for a number of reasons that we could talk about.
Maybe Joe first, and there's another question.
Thanks very much for the talk. I just wanted to ask you, how do we know that these regimens really work? I mean, we can say the patient doesn't go and develop TBCs, but you know, what about repeat testing afterwards? Do we really think that's a thing, given the way that interferon gamma has worked? We should maintain that immunological limit.
Yeah, I mean, I think there's some very interesting immunologic work, as you know, about test conversion and reversion and the long-term immunologic impacts of testing. From a practical point of view, I'm a simple guy. I say to patients in my own practice is that I do not expect your tests to revert after treatment. I won't routinely do them, because I don't think that what happens to testing post-treatment is helpful for us in terms of guiding therapy. So I don't think we have a clear answer to that. Clearly, a reliable test of cure would be a great step forward in latent TB management. There's some people in the room who are working very hard on that, some great work that Vanessa Clifford and others have done in this space, I hope that we'll see that in the future.
Is there any move to develop a fixed-drug combination of rifapentine and isoniazid? You kind of alluded to that.
Yeah, so there is, and there are some trials that I know the company is running around validating that internationally. I mean, as you know, but for the non-clinicians in the room, we don't currently have rifapentine as a licensed product in Australia. That's really a commercial decision, and so it's one that we've advocated for but have some limited control over. But our hope is that when the combination product becomes available, that will be an easier regulatory thing for us to bring in, because it would need to be registered separately anyway. At the moment, 150 milligrams of rifapentine and only 100 milligram tablets of isoniazid available in Australia just mean the pill burden, even for the weekly regimen, is reasonably prohibitive.
Last question, yeah.
Yeah, no, that's a good question. And just for the recording, the question was about neutropenia in the use of in the use of rifampicin. Yeah, so look, that's an interesting observation. It's not something that I have seen a huge amount of, but I've got to be honest and say there's a kind of therapeutic ignorance there because I'm not doing a lot of serial monitoring routinely through latent TB therapy. So for people who have a normal baseline, I won't repeat bloods throughout the course of treatment unless they're symptomatic. So while I haven't seen it as an issue, I might not. And I'm not sure if that means we should just ignore it because it doesn't seem to be causing problems, or if I should be looking harder.
Okay, well, thanks so much. That's true, Justin. So next speaker is Dr. Suman Majumdar. So Suman's an infectious disease physician who works at the Alfred and Epworth and is also attached to Burnett, does a lot of great work. He's living in Melbourne. We take some credit for success. He's from Brisbane originally, but is down here now. So we look forward to Suman's talk about some of the more relevant issues, maybe at a broader picture scale in the Asia-Pacific region.
Thanks, Andrew, and thanks for having me here. I'm not sure if I'll use my Queensland or Melbourne accent today, but I'll switch between the two for the audience. In the interest of time, I'm probably going to skip a few slides. I'm not going to give a didactic talk around TB in the region because it's too broad. I'm just going to give some lessons about some of our group's work over the past 6 years, specifically in some of the projects we've been implementing in Papua New Guinea and recently in Indonesia. To take a broader step back, though, the goal that we have in the TB response is to end TB. How that's defined is quite ambitious, so it's less than one case per 10,000 people by 2030, by the UN goals, or 2035 by the WHO goals. Now, the broad steps to get there are going to be to develop new tools. That's pretty clear from today. We need new science to do that. But we also need to do a lot better with what we have, a point Justin just made, which is the implementation gap. So a lot of what I'll talk about today is some of the delivery or the implementation challenges in getting these new tools or current practice into the high burden setting. The current rate of decline, it's going to take 200 years to get to this goal. So that's a bit of a wake-up call in terms of the pace of how we're progressing. But you picked the US there, but if you look at high income versus low and middle income countries with TB, there's a huge divergence in the disease burden. Now, I'm not going to answer the question, but I'll put some ideas up as to why that is, and everyone should be thinking about it. Is it weakened health systems? Is it vulnerability due to socioeconomic development? Or is it bug or host factors? Look, there is, I think one part of the story is certainly that there has been a failure in science and policy implementation in TB over the past period. We've seen a lot of progress and steps to correct that recently, but certainly there has been a divergence in policy around TB treatment in low and middle income countries and high income countries. So some of these gaps have been, and we try and conceptualise it in terms of detection, treatment and prevention, which is a standard epidemiological approach. We can see that we're not finding enough people with tuberculosis. We're not effectively treating, and certainly not effectively treating, drug-resistant TB. And there's a lot of people at risk with latent infection or at risk of acquiring TB, and it's hard to know who to target with what intervention in that group. So the whole basic tenets of epidemiological control are very hard to address, and which is why we're not getting there. But there are a couple of things that we can do in that framework. So firstly, we have used extensive active case finding in high-income countries in the post-war period, in North America and here in Australia as well, where there was quite a well-established public health campaign with incentives for people to get X-ray screening and treatment. More recently, there's been quite a groundbreaking study by colleagues who work with us in Vietnam as part of the TBCRE, but at the University of Sydney, Guy Marks, Greg Fox and others, and I think Jen is here today as part of this group previously. So this was a randomised trial of community-wide case finding with GeneXpert that was across 60 sub-communes in Vietnam. And the summary was, when they looked at prevalence of active TB at 4 years after that community intervention, there was a 56% reduction in prevalence of active TB. There was also a reduction in the risk of latent infection in young kids, indicating that there may have been a reduction in transmission throughout this. So certainly it is possible to have a huge impact on TB rates with interventions. The next question is how costly are they, how feasible is it, and how can you deliver these interventions? Drug-resistant TB has been an added challenge into that, into TB control efforts generally, and that's been more recognised since the 90s onwards. So the first challenge around the regional TB response is drug resistance, and from the graphic up in the top, our region, being Asia and Pacific, does have a very high burden of drug resistance, particularly India and China, but other countries such as Papua New Guinea particularly have a higher burden. Phil showed this figure before around the gaps in the MDR cascade, and there are massive gaps around detection through treatment and cure for MDR-TB. And sorry, Ben alluded to the transmission, I think, as well of MDR-TB strains, and that has been shown that transmission is driving drug resistance. It's not generation of resistance. The second earlier observation historically is this study, I think that also Ben referred to, around the Alaskan work by George Comstock, which was again one of the first studies of a public health intervention of case finding and also giving isoniazid prophylaxis to contacts at a community-wide setting, which showed a dramatic reduction in TB infection in young kids, and over the long term rates of TB dropped from 500 per 100,000 to rates that were consistent with the rest of the United States populations. So that hasn't been replicated in many other settings historically. You've just seen a gap between the rich and the poor basically in TB rates. Having said that, the effectiveness of preventative treatment has largely been ignored from a policy sense, which is what I was referring to before, where multiple numbers of studies have shown large reductions in mortality and also large risk reductions in development of active TB. The question is, who do you target with this intervention that we know is effective, and how do you deliver it? So the second challenge I'll talk to is about scaling up preventative therapy to end TB. So there are some targets that we need to scale up, particularly looking at household contacts who we think are at highest risk. And there's been change in policy to say that we should be looking at young kids, people with HIV and household contacts to deliver prevention. And these regimens are coming online, so let's get the delivery systems in place so we can deliver new interventions. So moving to P&G, I'll probably have a lot more on the screen that I'm going to go through, so I'll just give you the key points that overall the estimated notification rate in P&G is around 480 per 100,000. There has not been a prevalence survey in the country. There's a wide confidence interval around that estimate, but within the country you see quite a heterogeneous notification rate with high burdens in the southern regions, but as we are looking more in each province, more cases are being notified. Now, having said that, there's quite a low rate of bacteriological confirmation. The lab services, like many low and middle income countries, are not well established, and Expert was only really scaled up. Now, it is in all provinces, but that was only in the last 4 years where there was a scale up of Gene Expert. Prior to that, it was smear microscopy. There's a culture lab, and Chris's group has helped establish services there through support over that time. But you can see with the epidemiology here, firstly, there's a high burden in adolescents. Young children aren't being detected, but they're probably likely to have significant TB. There's a lot of extrapulmonary TB, which is odd, and we're not sure what is driving that. That could be just clinical diagnosis for other causes. And treatment success is not optimal at 64%. The higher rates are lost to follow-up, and there is emerging drug resistance that are in various pockets of the country. So just to, I'll talk a bit about our projects, but just to acknowledge members of the group and team that are here today. So I've co-headed the group at Burnett with Philip, Kai and Danny are in the audience today, and Steve Graham, who's not here, has also been a key member of our team. And some of the projects we're involved in are in PNG, where we're working in Western Province in Daru, in the lab in Port Moresby, in the New Guinea Islands, and also starting up new work in Indonesia, which I'll go through. So firstly, just talking about some of the work in Western Province in Daru. This work since 2014 has been supported through the Australian Aid Program by the Australian Government, but it's a partnership. We work exclusively through PNG Government and with a range of partners there, including NGOs and the local government. And secondly, we've been working in a regional collaboration with Menzies from Darwin that adds on a research component into that technical assistance work. So Western Province is north of Queensland, borders Indonesia, and is the largest province. It's very remote, and it's about 200,000 people in the entire province. What we've seen, and I think some of you should be aware of this, is that there has been a very unprecedented outbreak of drug-resistant TB centred in the southern part of that province on the Torres Strait border. So there is a publication where we've documented some of these rates now in Public Health Action, but if you look at the South Fly district, which is the bottom third of that province, the overall TB case notification rate is around 1%. In Daru, which is the capital and the island there that serves that area, if you look at the catchment area of that, the rate is 2.6%, and MDR-TB is 0.6%. Genomic work by the Queensland guys, Arnold, Chris and Ben were involved in this, showed an outbreak strain or a single clone responsible for that transmission. So the public health or the programmatic response to that has been really to develop a delivery system, firstly in the hospital with clinical support, expanding that to the community, then going through the steps of active case finding, and then we're looking at household contact screening and prevention measures around that. Now, it's been quite a slow process to get through those steps, given the really fragility of the systems there, from supply chains through to governance, through to coordination. But to give you a snapshot of the progress over that time, from the detection point of view, there's been a screening initiative with an X-ray truck with artificial intelligence, CAD for TB and Gene Expert to screen the island population. That actually had quite low uptake and quite low reach because it was fixed point screening. There's also been contact screening, which, sorry, that should be 2.3, not 23% as the overall yield. That would be way too high and too good. From the treatment side, there has been an improvement in success rate of MDR-TB from around 50% to 88%, and the utilisation of newer drugs, including 190 patients on bedaquiline and 15 on delaminid. And we've started to scale up prevention activities at the household level, particularly starting with prevention in child contacts, introducing 3 months of rifampicin plus isoniazid as a regimen, and we've initiated levofloxacin for MDR-TB contacts kids. I'll skip that impact evaluation, but there will be a review published on the DFAT website in the coming months, they tell me. Another key intervention or project that's been part of this has been building research capacity as part of the response, and through one of the grants, we worked with health workers who were on the front line in Western Province and 7 other provinces to conduct some very basic clinical and programmatic operational research from various parts of PNG, and that's put together in this compendium with 14 papers, but it includes the experience from using bedaquiline and household contact tracing in Western Province. So the program here is a community-based model with 4 treatment sites around a central hospital, which is pictured there. From the diagnostic point of view, Gene Expert is the frontline diagnostic test with ultra cartridges now in place. Culture and DST is performed, so I need to update that now, it's performed in Port Moresby, but backup second-line DST in reference labs in Queensland. There's basic biochemistry, plain X-ray and ECG and audiometry, but often a lot of ruptures in these ancillary testing for the patients. The program has had, and I'll describe this, focus on social adherence and psychological support, and also food support for patients. So we're seeing about, in a year, about 500 people with TB, usually around 100 to 130 with MDR-TB, and the rest with drug sensitive in this program. And our work has been really around the training, developing SOPs and clinical guidance around that, but also development of the model of care and the public health approach. We've also established a patient-level electronic medical record system that's owned by the provincial government and hospital. So a quick snapshot of the initial experience with bedaquiline. There's been a lot more since then, but Maggie Tano, who's a physician working there still and doing a fantastic job, published this paper last year on the initial experience, which was scale up from compassionate access to pilot access bedaquiline before guidelines were changed. But since 2016, we've really been using what is the recent WHO long oral regimen with bedaquiline, linezolid, clofazimine, and levofloxacin as the core drugs in this regimen. The sign of first injectable toxicity has been a switch to bedaquiline, and that's what this describes. About 20% of patients had injectable toxicity, with ototoxicity being quite significant. The outcomes for this group, basically it's non-randomised, so you can't really compare the two groups. We looked at bedaquiline and non-bedaquiline, but we had quite good retention in care rates. The bedaquiline group were actually sicker because they were XDR and pre-XDR TB, and they actually had less death for what it's worth. And the culture negative rates at 6 months were above 92% in both groups. This had to be implemented with active drug safety monitoring, which involves really only looking for serious adverse events, but ECG monitoring as part of the protocol. There could be much more improvements in the culture monitoring. The supply chain to get cultures out often breaks down, but the ECG monitoring was quite successfully implemented in the program. There were not many adverse effects in that program, and off-label, i.e. extension of bedaquiline beyond 6 months, was used as well. An important part of the program, as I mentioned, is education and counselling support, and that's been a key add-on to the program through a separate pilot project of peer counselling. So people from the community in Daru who had TB or experienced MDR-TB themselves have been trained to be peer counsellors for direct patient care, but also family-based and support group care. And that's been a model that's now been developed into a toolkit that can be potentially scaled after the past 3 years. So they give us a very standardised amount of sessions of education and counselling for patients with MDR-TB, drug-sensitive TB, and now for latent TB treatment or TB prevention treatment. And this is done in the community sites and in those 4 sites that I mentioned. So they've been the PALs are the peer counsellors, so 10 of those have been trained and 3 lead counsellors, and there have been about 15,000 individuals supported through this over the past 3 years. And the satisfaction surveys have been positive. There's some qualitative research the IMR is doing on the model of care that we're awaiting results. Some of the issues, just to give you a reflection of, if you look at just the various issues people have raised, side effects is quite predominant, but also domestic violence, stigma and discrimination, alcohol have been also reported. So stigma is still quite high despite this TB being in this community for quite some time. But this program has really, I think, catalysed some empowerment of the community to take to actually be quite involved in the program and take it out of hospital care into a community setting, and it's developed packages that could be used in other settings, and that's what we're going to try and do in the next couple of years. The next part of the program I'll just describe is the contact tracing and prevention program, which has been taken out of hospital into the community sites, and this is an ongoing study that we're recruiting patients into, so it's just some interim results of this experience. We've published the first part of the contact screening model as part of the operational research training. So there were 2 periods. The first one was the current guidelines, which was contact screening and prevention for kids under 5. And the second period, from the start of last year, we added onto that tuberculin skin testing, a shorter regimen for young kids for drug-sensitive TB contacts, and introduced levofloxacin for MDR-TB contacts, thinking that there was significant equipoise to do that whilst awaiting those trial results. Now, progress in these settings is always slow. We had to firstly conduct community engagement around this, develop tools and translate the paper tools into an electronic system, because we are following individuals. And we've developed patient-centred education and counselling tools as well for latent TB, which is called sleeping TB in the community. And that's been a really key part, because as Justin alluded to, treating well people is a challenge, particularly when there's many other issues that they have to deal with. And TST was not available in the country despite being part of the guidelines, so we had to get that in place, Interestingly, nurses had been trained 20 years ago, but it hadn't been used since, so we reinitiated TST testing. So the model was just going from index cases to the households, evaluating them at the hospital, if they've got active TB, doing the TST testing, then the initiation of prevention was done at a community site with family education and counselling. So we've had about, over that 3-year period, about 5,500 contacts screened, and I won't go through all the numbers here, I'll just give you the headlines, which was that of those screened, about 20% were symptomatic across both periods, and about 10% had active TB, so the yield was 2.3% from the screening part of view. From the prevention point of view, these are only interim results. We've had very high uptake of prevention in both periods, above 98% of people who are eligible actually getting on to prevention. The initial period with 6 months of isoniazid, there was quite a lot of initial loss to follow-up, whilst I think the tools and the engagement was catching up. But in the last year or so, it's been a completion rate above 90%. There's been quite minimal adverse effects, actually. Now, keep in mind, we're only treating young kids, and we don't expect the kids to have many adverse effects. So we've initiated, so that's now 12 kids on levofloxacin, and there haven't been any serious adverse effects on that. There's been quite a lot, because it's a consent, it takes a bit of time from identification to initiation of those kids, and we thought we'd actually initiate quite a lot more than 12 over that period. An interesting finding, and this is certainly one for comment rather than a conclusion, is that there was a high prevalence of latent TB infection on TST testing in the households, as you would expect, but there was interestingly quite a lower rate in younger kids. So this is MDR, you probably can't read that, but this side here with the arrow is MDR TB households, and these are drug-sensitive TB households. Oops. And the average is around 50 to 60% across the board, but if you look at those above 15, the rates are 70, 75%, a bit lower in the drug-sensitive, but under 15 it drops quite low, and under 5s the rates are quite low. Now the BCG rates in this population, they were stockouts, so it's only about 20%, so that's not giving false positives at all, and we were pretty confident with the supply chain of the tuberculin in that setting. So to us, this does suggest that potentially the transmission may not be occurring in the household per se, it may be actually occurring in the community. We're thinking that adolescents actually may be driving more of the transmission in the community, or places where people congregate in this setting. So the key early findings were that firstly, that there was a functional model developed with high rates of uptake at this point. There was reasonable detection with contact screening, and we've shown that there's high prevalence of infection in these households. Now, I shouldn't say infection, but it's having a positive TST test, because you're not sure which of those people are actively infected at that moment for TB. So the challenges have been risk-benefit assessments for MDR-TB. Certainly the fact that people have had mixed contacts, so they might have a drug-sensitive contact but then also have an MDR one, or there's people that have, you think they're a contact of a sensitive strain and then they develop MDR-TB, which again supports outside the household transmission. And we're at the phase now where we're looking at the next response in this outbreak, where I think the step forward is probably to go to an expanded platform for prevention to older contacts, and particularly the adolescent group. But that would be well beyond guidelines, looking at high burden MDR setting and having to use a drug like levofloxacin in adolescents and adults. Done some modelling and costing of those scenarios, and I won't have the time to go through this in detail, but other than to say this is a transmission model that looks at the impact of, this is up to 2018, withdrawal of services, screening for active TB alone, and adding on prevention through contact tracing, and then adding on prevention through systematic testing and treatment of everybody on the island. Now we haven't we modelled the current rates of the program that we had, and we didn't model mixing or movement of people, so we considered it a static group. But the biggest impact was seen with a test and treat all for active and latent disease. Costing showed that despite a bigger upfront cost for that program, it reduces the downstream cost because you reduce the disease burden, which is not a surprise, but it's quite effective for advocating to move forward. I'll probably skip over that one in the interest of time. I will highlight one study that is about to finish next week, Philip, I hope, which is the diagnostic accuracy study of the Molbio TrueNat study in the central lab in Port Moresby. It's part of a multi-centre study sponsored by FIND. So Dr. Lavie, the head of the lab, along with Philip and others, have been part of that team. And it just a parallel testing sample to look for TB and drug resistance. Now, this device is a micro PCR still, so it requires a lab, but it can be battery powered, and it can also be a multi-disease platform as well. So it could also be a cheaper test than Gene Expert. So it may have a role in certain settings for detection. So moving on past PNG, I'll just talk about TB in Indonesia, where we've recently started up some work. So Indonesia is one of the number 3 on the high burden countries for TB. And the prevalence survey a few years ago found that in those above 15 years, the prevalence was 759 per 100,000 across the country. So quite high rates. Eastern Indonesia seems to have higher rates than Western Indonesia, and Yogyakarta province is one of those settings that seems to have higher burden of TB. Now, this is a program of work that Philip actually is leading on that I'm not as familiar with, but I'll give you a quick overview. So this is an initiative that has been constructed over the last 3 years after we conducted some training in Indonesia with Menzies and University Gadjah Mada, and part of a broader global movement called the Zero TB Initiative. And the aim was to try and look at reducing rates in Yogyakarta province over 5 years. And we've got 2 support sources of funding, a TB Reach grant for case detection, and a recently started DFAT grant to work there with these local partners. So importantly, it's a local coalition with the provincial government, the UGM as the local partner to implement this and providing support. So the TB Reach project, which is in its first or second month at the moment, is to look at detection of active and latent TB. Now, in the province, there's about 3.5 million people, but in the areas we're looking at, it's around about 900,000 people. And there's a couple of zones within in this area where the intervention will be. So there's control and intervention districts. There are 5 populations that will be screened by a couple of methodologies. So a mobile X-ray van. They'll look at slums, boarding schools, and then a car-based team is looking for active and latent TB as well via households and healthcare workers. The 5th group is females attending female-run community posts. So this is just starting up, so I haven't got results to show, but they have started screening. This is a picture from this week, I think, and then there's the mobile bus has also started as well. So another key part of this initiative is the gender element and the empowerment of women and girls throughout the program. So firstly, it's led by an all-female team from Indonesia, and part of the analysis will be looking at services for women in particular, and integration with maternal and child health services there. So I'll end up there. We just found out this morning that we've been successful in a new regional grant through the Centre for Health Security in DFAT, and we've been working on this for a number of months, but happy to just give a very quick outline. It's called Prime TV, that tries to link up PNG and Indonesia. It's a grant that will focus on workforce development and outbreak responses, and the implementation of innovations in a number of sites. So this Jakarta project being one of them, linking in the lessons learned in Daru and translating them to other parts of PNG, particularly a focus in Port Moresby, and Menzies through Anna Ralph and Sasi are working in, Trisasi Lestari been working in Mimika district in West Papua to support, again, a household model of TB services there with prevention. So that's quite an interesting program of work there. So sorry for the whirlwind tour, but I've got through that. So happy to stop and take any questions if we have time.
Any questions at all? Ben?
Just want to ask about the infection rates in Daru. It's amazing. Figures low household infection rates in children.
Yeah.
High rates in young adults and adolescents. So in the Inuit studies, that approximately there was never indication that transmission was happening in households of 78%
Yep.
infection rates among the Inuit community. Is there any sense of where these young adults are transmitting disease? Is that part of the social science or the young adults?
Yeah, and the preliminary, the findings, I guess I haven't given us the analysis of that, but there are some congregate settings where adolescents will gather. Often there's people that smoke through a water pipe. There's also sporting teams as well, and then there's churches. So we've had a couple of community consultations to identify these sort of congregate settings. So we haven't got data to say that they are hotspots. We haven't done a social network analysis, which could show that. But I think one conclusion is it's a small place, but even if it's in the household or not, you'd consider the island as the household, and an intervention to look for TB in everybody is probably the way forward. The household is still important as the delivery mechanism because you need to follow up people for months, and mapping people back to households will be something we'll still need to do.
I wonder, do you see a lot of eating up children and the adults in the population in Daru, and is there any evidence or is there any possibility to get that for a source of transmission?
Yeah.
Which is a practice where basically chewing up needs to be spitting out, particularly often amongst adolescents now. That's a potential source of transmission.
Yeah, no, it's a really good observation, and I mean certainly there is in PNG. There's no evidence I know to confirm yes or no whether it's a factor, but certainly it could be. But I think also, particularly for Daru, one major difference there than many other parts of the country is the intense overcrowding. So it's a very densely populated, almost slum-like community, and throughout the country in PNG you see that there are variations in household size from highlands to coastal areas, depending how families live. So, my own feeling would be that it's actually around overcrowding as probably the bigger driver, but it's always going to be more than one factor.
Great. Well, thanks very much. So that's a brilliant talk. So our last speaker today is Associate Professor Dan O'Brien. So a lot of the focus has obviously been on TB and pulmonary mycobacteria. So we've got something completely different from Dan today. So Dan's a clinician, RD physician, Barwon Health. He's obviously got a strong interest in his topic of conversation today, mycobacterial malcerans. Been involved with MSF, with TB programs overseas, and also obviously with WHO with malcerans. So thanks, Dan.
Right. Thanks, Andrew and Jason, for asking me to speak. And I realise it's the last lecture of the day, and it's actually nearly over time. So hope you can bear with me and stay awake. There is some interesting pharmacokinetic implications coming right in the last 5 minutes. So, look, this is really a clinical talk in a way. It was pathogenesis and treatment, and although the epidemiology is very interesting, I haven't got time to talk much about that. But we have had a lot of clinical experience with this disease in Victoria because we are facing a worsening epidemic here, which is keeping us very busy. And we've learned a lot of lessons as we've gone along around the clinical care of this disease, which is reasonably complicated at times. So just a little bit about the pathogenesis. The most important thing is that M. ulcerans has a exotoxin called mycobacterial, which does three things which are really important to its pathogenesis, but also how it responds to treatment. One is it's a toxin, so it causes necrosis and cell apoptosis and death. So you get the classic ulcer with some surrounding induration and an undermined ulcer, which is the classic thing. But it's also immune modulatory, so it paralyses the immune system both locally and a little bit systemically, which is one of the reasons why it's difficult to eradicate. And the third thing is it produces an anaesthetic agent, so that people actually often don't notice the ulcer, and the classic thing is that they're painless. My experience really arises because I developed an interest in non-tuberculous mycobacteria when I was in Darwin as a registrar, when Jesus was playing fullback for Nazareth, and I turned up in Geelong in 2000 just to coincide with an outbreak of M. ulcerans, which really developed from there, which has been focused on the Ballerine Peninsula. Here's Geelong here, for those who don't know it, and this is a little peninsula. We've had disease appearing really just in focal coastal towns on the peninsula. And over time, we've seen an increasing number of cases. So in the last 3 years, we've seen more than 100 cases a year. We used to think we were busy when we saw 14, but we've been much busier lately. And I've also had experience working with MSF with the disease in Africa, in Cameroon specifically, where it's not coastal, it's actually inland around river basins, and more recently in Papua New Guinea, where we're working with the TB. There's also Brewery ulcer in that part of PNG, which, as you can see, is really quite severe. Brewery ulcer has been reported from 33 countries worldwide, and you can see it's mainly focused in West and Central Africa, but it is found in South America, certainly in Papua New Guinea, as we've said, in our region. And Australia has the sixth highest number of reported cases per year. But Australia, it is basically focused in Victoria or in small pockets of far north Queensland. One of the reasons we've struggled to get money, I guess, to look into this further is it does only affect a few postcodes in Australia. One of them happens to be the Health Minister's one, though, so that's handy. So what's happening in Victoria? Well, three things are going on. One is the number of cases are increasing significantly for reasons that are unknown. And one of the important things about this disease is there are so many unanswered questions, and it is a WHO classified neglected tropical disease because it has been neglected. So there are a lot of things going on around epidemiology which are really not understood, and one is we're seeing an increasing number of cases. So in 2018 we saw 340 cases in Victoria. It is notifiable here, so we do think we get most of the cases, but you can see cases increasing. Not only that, the disease is moving. So it did start out in East Gippsland, as I said before, they're first recognised in 1948. Then in the early 90s we saw cases in Phillip Island. It then moved into the Frankston-Langwarrin region, and then turned up in the Bellarine Peninsula at the turn of the century, then turned up in the Mornington Peninsula in sort of about 2012, and now is moving up towards the Bayside suburbs. So you're sitting here, so it hasn't quite got here yet, so everyone's safe, but it is on its way up. And now, in the last 2 years, it has turned up in Geelong, and now down on the Surf Coast. So it's moving, and once again, the reasons for that are not clear. And the last thing is, if you look at this purple line here, is what we're seeing is a high proportion of severe cases. So in our experience, and I don't think it's a referral bias, we actually are seeing probably double the number of severe cases than we did see earlier in the epidemic. And people think because Australia's got a good health system that therefore we don't see severe cases. It's not true. Up to 25% of cases that we see are actually severe. And therefore, not surprisingly, there certainly has been, up until the advent of the coronavirus, reasonable community concern over the disease. We may have been a little bit drowned out lately. This is the only epidemiology I'll say, and that is just to point the finger at the possum. I think it's pretty clear that this is the reservoir. It's intimately involved in the transmission and probably the movement of the disease. My theory is you can't protected species, but if you if you did a survey of the population, I'd think about 4 to 5 in 10 people do catch possums and move them somewhere else in their community so that they don't come back and annoy them. So what we know is if you look at human disease and you look at possums, possum faeces is strongly PCR positive, And where it's positive in the red spots, this is down on the Mornington Peninsula, that's where you see the human cases. And that's been replicated in quite a number of settings, including in Geelong recently when we had our outbreak of the disease in Belmont, where in fact where the possum poo is positive is exactly at the front of the house where the person has the disease. So exactly how it gets from the possum to the human, how that's all related is not entirely clear, and there's a number of theories, but clearly they're intimately related. Now, the classic thing is, of course, it's an ulcer. That's why it's called the Bruley ulcer or Band-style ulcer. But, and you get, as I said before, this yellow necrotic skin with necrosis and, most importantly, an undermining with areas of induration around it. 5% of cases will have more than one ulcer at the start, but importantly, at least 15%, but even up to 20% are not ulcers. So that's where there's sometimes a diagnostic delay, as people think it has to be an ulcer. Well, about 8 to 10% are in fact nodules, which is really a pre-ulcerative stage. It will ulcerate in time. In Africa, we don't see this so much in Australia, but in Africa they can get this subcutaneous swelling or a plaque type lesion, especially in children. And then the really severe lesion, which is the biggest concern really for everyone, is the edematous or cellulitic type form. And this is really very aggressive and causes really rapid and severe tissue destruction, and it can occur in up to 10% of cases. So it's commonly over a joint, around elbows, knees or ankles, sometimes wrists. So the key is, if you see cellulitis in one of the endemic areas, is to always think about hemulcerans, because if you don't test for it, there will be a lot of damage done before it's diagnosed. WHO classifies the disease according to 3 categories, which really revolves around the size of the lesion and also the number of lesions. I really just want to bring it up to say that in Australia we have about 20 to 25% are category 2 and 3. So once again, severe disease does occur in our communities. It's not just due to, and it's not related to delay in healthcare acquisition in Australia either. The duration of symptoms is actually less in people with severe disease than those with non-severe disease. It more reflects the severity of the underlying disease. But these just are a couple of cases. Here's a lady who had 13 lesions. Here's a lady with a severe lesion on her ankle region. What we don't seem to see is osteomyelitis, very rare, probably 1 or 2% at the most of cases in our experience, whereas in Africa it's reported in up to 15% of cases. That may relate to delay in diagnosis, I'm not sure. Early diagnosis is the absolute key because it has a huge implication on a number of levels, but this is when you've got the lesion nice and small with minimal surrounding induration. What it means is you've got much more rapid healing times with treatment, reduced need for surgery, a reduced duration of antibiotics that we've shown recently, but also importantly a reduction in long-term deformity and disability. So really the public health awareness and the clinical efforts are really around trying to diagnose the disease as early as possible. The best test, which performs very well, is the PCR test. It has a very high sensitivity and specificity, but like any disease in real life, in fact, it doesn't perform that well in practice. And what we've seen is that about 6% of cases that we see have had an initial test which was negative. It probably relates to specimen collection and transport. But the important thing is that it often leads to misdiagnosis and delayed diagnosis because people are thinking they've done a PCR and it's negative, therefore the disease is not present. If you swab a non-ulcerative lesion, it'll be negative, so that's clearly one of the issues that people have. But two, like anything, if you have a suspicion that the disease is there, it's important that you repeat the test. And ideally, if you get a negative swab, you would do a biopsy, especially, of course, if it's a non-ulcerative lesion. So I think the key is just to be aware, like any test and anything in medicine, don't rely on one single thing to tell you whether or not the disease is present. Now, I want to move on a little bit onto treatment and talk a little bit about the role of antibiotics, the role of surgery, management of paradoxical reactions, and then some of the newer developments. But There is guidelines that have been published in the MJA in 2014. They are a little bit out of date and need to be updated with some of the more recent findings, but they are available. Some of the members in this room have been involved in producing them. And what do they basically show? Well, it used to be thought to be a surgically treated disease, of course. You manage it like you would a melanoma or skin cancer with wide surgical excision. But it's clear now that antibiotics are highly effective and they are the first line of treatment. And the recommendation, both in Australia and with WHO, is 8 weeks of a drug combination. In Australia, we've been using oral agents for nearly 20 years now. WHO has just come around last year to agree that in fact you don't need an injectable agent, but basically rifampicin plus either a fluoroquinolone or clarithromycin are the regimens that we've used. Surgery is absolutely not required to sterilise lesion, and that's vital, okay? So surgery absolutely has a role, and we'll go through that, but it's not there to sterilise lesions, it's there for wound management. Ideally, if you're going to operate, we'll try and get a few weeks of antibiotics in just to shrink the lesions and therefore minimise the amount of surgery that's required. I'll show you some of our figures later, but what's clear is if you give antibiotics alone, that they work. Here's a lesion at 2 weeks into treatment and 9 months after an 8-week course. You can see that it's healed very well with really minimal scarring. But the important thing is that the antibiotics don't get rid of the ulcer overnight. And what a lot of people run into trouble with is the fact that the ulcer doesn't necessarily behave that well when you treat it. You need to understand and let your patients know a number of things when you're treating them so that they don't get disappointed and you don't think that the treatment's failing. The first thing is that this is just a graph which plots the percentage reduction in the amount of induration around the lesion, so not the ulceration, but the induration, and a density plot to show you that most people will get quite a significant reduction in induration, a median of 40% in those first 2 weeks. So it looks better in your first 2 weeks, so everybody's happy. But what happens over time, once again, if you look at the percentage of increase in ulceration and the density, is that most people, in fact 70% of people's ulcer will get bigger in size, and the median increase is 45%, so that's nearly doubling in size. And so therefore it's really important that people understand that the ulcer is going to get worse before it gets better. So the fact that the ulcer is getting bigger is just the way the body heals itself. It's got nothing to do with whether treatment fails or not. And the third thing is that it takes a long time to heal. So the average time to heal is 137 days, okay? And how long do the antibiotics go for? 56. So what it means is when you finish your antibiotics here, almost nobody has healed their lesion. And patients are quite surprised, and clinicians as well, that you would stop treatment while you've still got a big lesion that's actually looking worse. But that's the natural history, and you don't need to keep up the antibiotic treatment. And what's clear is that, of course, the healing time will vary according to the size of the lesion, and so what you can do is there's some very good prognostic information here. If it's less than 2 centimetres, you can say it's going to take you 3 months to heal that on average. If it's 2 to 5, it's going to take you 4 months. If it's more than 5 centimetres, it's going to take you 6 months. Okay, and that's really important information to give up front. But the second thing is if you develop a paradoxical reaction, and we'll talk about that in a minute, that's going to increase your healing time by 6 to 8 weeks, so that in fact it can be quite prolonged if you get paradoxical reactions as well. And that what's clear if you look at the time until the induration resolves on treatment and the time until healing begins here on the left, that you actually don't start to heal until your induration has resolved, i.e. the amount of inflammation around the wound needs to have settled before you heal. So if you're looking at a lesion and it's still inflamed, it's not going to start healing. And we'll talk about ways to minimise that inflammation to try and increase the rate of wound healing. And we published this a couple of years ago if you're looking for those figures and the natural history of the disease. Now I mentioned paradoxical reactions because almost certainly this was what happened when people decided it was a surgically treated disease, because what happens is when you treat with antibiotics in at least a third of cases, but maybe even more, you get a paradoxical reaction occurring. And this slide on your left shows what the histopathology looks like prior to treatment, and that is almost no inflammation around with lots of necrosis and dead cells or dead fat cells or ghost cells. Why? Because you've got immune paralysis, remember. Treat with antibiotics, and within 6 weeks you'll get a very much significantly inflamed lesion with even some multinucleated giant cells because you've killing the organism, basically. Likewise, lots of AFBs at the start. On treatment, the AFBs go away. But what happens is 1/3 of cases, they get really inflamed. It's not a failure of antibiotic treatment. It's a paradoxical reaction, exactly as you get in tuberculosis, leprosy, MAC, all other mycobacterial disease. And in fact, rather than a failure, it's actually an adverse consequence of effective antibiotic treatment. And recognising this was a game changer because it meant that instead of thinking you've got to change your treatment or persist with your treatment, all you're seeing is what we see in leprosy and what we see in TB is that often you will develop a worsening clinical picture due to the success of your treatment. Why? M-ulcerans kills the bacteria, reduces the production of mycolactone, so it reverses an immune inhibitory state, but also, of course, releases mycobacterial antigens, so you get a reaction. And I'll just show you this in just a pictorial way, in a graphical way, the natural history of the disease that we've been talking about. The blue columns represent the amount of induration, which you can see. You just measure it like you would a Mantoux test, okay? And the purple is the size of the ulceration. First few weeks, you get a reduction in the amount of swelling around the lesion. That's normal, with a slight increase in the size of the ulceration, so that by 6 weeks, it's still inflamed and the ulcer's got bigger, okay? So it doesn't look much better. It probably looks a little bit worse. Then over time, when the scab's removed and the inflammation resolves, then the wound starts to heal, so that by 4 months, your wound has healed. If, however, you get a paradoxical reaction here, you can see the amount of inflammation going down, so it's looking a little bit better, but then you can see the inflammation significantly increasing and the ulceration has significantly increased. So do you think at the, what is that, that's a 6-month mark, that the patient thinks that you know what you're doing? Or you think you know what you're doing? No. But in fact, that's just an immune reconstitution reaction which will heal in time, but you can see the effect that the paradoxical reaction has on the way the organism, the ulcer looks. The really difficult thing is to know when you are truly failing treatment and whether it's just the natural paradoxical reaction that you see in most cases. I think the main thing is you actually look at it, and you get the yellow necrotic. This is failure on the what's it? Your right. It's yellow. It's actually a clinical thing. It looks different, whereas a paradoxical reaction still looks healthy. It's inflamed, but you can see that's a much healthier looking tissue. And if you really want to, you can biopsy and have a look under the microscope and you'll be able to tell the difference. But in general, clinically, you can tell. Right. Today we've talked a lot about antibiotics, and one of the big problems we have in our patient population, and it's probably median age has got a bit to do with this, is antibiotic toxicity. So the first thing is 1 in 5 patients will have to stop at least one of their antibiotics during treatment, okay? And if you're over the 65, it's 2 in 5, okay? And we're talking about a significant number. I think it's about 10% of them ending up hospitalised through the severity of their antibiotic complications. So it's not minor. Second thing is the median time to antibiotic complication is 28 days. So that means that even after your first 4 weeks, you're still at risk of toxicity. But on the other hand, if you can reduce your antibiotic treatment to 28 days, then you can reduce your antibiotic toxicity rate by 50%. So that's important to understand. There are some risk factors for antibiotic toxicity. One of them is your renal function. So here, if you've got reduced renal function, eGFR 60 to 89, you've got a higher risk of complications than those who've got better renal function. But I was also talking again today that we also found that there's some gender association as well. And the fact is that women are at a higher risk of complications than men with these medications. And I think that probably relates mostly to the fact that women probably have higher levels of antibiotics in their system. We haven't measured this, and that puts them at a higher risk of toxicity. But that's something that really needs to be looked at. The role of surgery, as I said, it was a medically treated disease. Sorry, it was a surgical treated disease. It's become a medically treated disease, but the pendulum is swinging back again because there is definitely a role for surgery, and it can be used in many different ways. I'm not going to go through it all in detail because I haven't got time, but just to say we published a paper last year in the ANZJS, mainly directed at surgeons to try and stop them doing wide major surgical excisions, but it just does run through a number of different ways that surgery can be used: wide excision without antibiotics, curette, antibiotics plus surgical debridement, conservative excision, wide excision plus antibiotics, and the indication, advantages and disadvantages and timing of all of those. I'll just touch briefly on it. You can cut it out with wide margins. It is a reasonably big wound, and that often surprises patients, but it will heal much quicker, and you don't need antibiotics, and as we said, they're often toxic, so that is a big advantage. But you need to be sure you get it all out. If you've got positive histological margins, it will come back, and there are some other factors that may reduce your chance of cure that you need to consider. What we have found, though, is you've actually got small lesions and you curette them, so you take out the macroscopically abnormal area. Not only will it heal quite well, but you can reduce the duration of your antibiotic treatment. So you only need 4 weeks of antibiotics if you curette those lesions. And that's just a local anaesthetic that can be done by a GP in their rooms. Okay, so that was based on the fact that we noticed that these are patients who had antibiotics plus surgery and mainly had to stop their antibiotics early because they had toxicity, but also as we started to have success with this, actually reducing antibiotic durations. But if you've had more than between 14 and 28 days of antibiotics, you will still cure regardless of whether your histological margins were positive. And so, in fact, we probably get quite a benefit from removing some of the infected tissue by surgery as far as the duration of antibiotic treatment that you need to have. So one other thing just to quickly mention, that debridement's important. Here's a wound at 10 weeks. You can see it's still inflamed, it's not healing. But if you actually surgically debride that and clean that all out, then it will heal very quickly afterwards. Why? Because remember I said it doesn't heal well while it's inflamed? Well, if you debride a lesion, you get rid of the stimulus for the inflammation. The inflammation resolves and the wound will heal. So debridement is actually a really good way of trying to heal wounds more quickly. Doesn't have to be surgical. This is just an example of someone who had debridement in the clinic. You can see here it's a large lesion, more than 5 centimetres. Good debridement in the clinic. By week 5, it's looking quite clean. By week 13, it's totally healed. Remember I said normally for a 5 centimetre lesion, it's a 6-month healing period. This healed within 3 months. So good care in clinics with debridement and dressings actually normally saves you 1 to 2 months in healing time. So I do encourage people to go to clinics often. If you're down here in 13 weeks and you're still not healing very quickly, you can just excise the lesion and you'll heal up in a couple of weeks, but it does involve a significant scar and a cost. But the most important thing is we don't want wide surgical excisions with reconstructive surgery anymore. Should never happen anymore, but it still does. So there's a big role for educating our surgical colleagues. And here's a small example of a small lesion on the anterior aspect of a shin, which would have healed very nicely with just antibiotics alone. We ended up having a big transposition flap done, which I think was quite disfiguring, and then they got a recurrence anyway. Lots of education. I'm sort of a bit short on time, so I'm not going to go over too much about paradoxical reactions, except to just show you again pictorially. You start off with this, you start antibiotics, you think, great, I've got it early, this is going to go well. Well, 3 weeks later it looks like that, 6 weeks later it looks like that, 7 weeks later it looks like that. Okay, that's just the paradoxical reaction and what happens in treatment. But what you can do is you can give steroids, which will settle down the reaction. So if you introduce steroids here, you get reduction in the reaction, but it doesn't really help with the time to healing. Wounds still take a long time to heal on the steroid therapy. What you can do, here's another case that's still very inflamed, 19 weeks into treatment, is surgically debride it. And by, again, cleaning up all that thing, it reduces the inflammation, allows the wound to heal. So that's often a very useful way of doing it. Okay. What I really want to talk about is the importance of being able to shorten the duration of antibiotic treatment because of the antibiotic toxicity. And I think we've shown reasonably well that with a recent study published in CID where we just looked at our experience with people who had 28 days to 42 days of antibiotics compared to those who had 8 weeks or more, the recommended duration of treatment. And we found that 100% had actually achieved cure. Okay. But But what we're talking about here is lesions that are mainly in adults, not so much kids. But more importantly, we're talking about small lesions. So they're lesions less than 3 centimetres in diameter, and they're all WHO Category 1 lesions. So what we're basically saying, it makes sense, is if you've got a small lesion, you don't need to treat them for the full 8 weeks. They'll do very well on 6 weeks of treatment maximum. Some people I even treat for 4 weeks now. So that's very useful as far as trying to reduce toxicity. But what I've just recently discovered is that we've been having... So antibiotics are highly effective. We looked at our experience between, well, for the last 20 years actually. If anyone who had more than 28 days of antibiotics, and 99% of people have been cured. So, and that's the experience worldwide. But we have had 7 failures, and they are more recently. And so I went back and had a look at those 7 failures because I was starting to worry that they're happening more often. Maybe we're getting some drug resistance or something. And in the cohort that we looked at, anyone who'd had really 56 days of antibiotics, we looked at about a little bit more than half were male, but 13% were more than 90 kilograms, 2/3 had rifampicin, clarithromycin, 32% had rifampicin and fluoroquinolone as their first-line antibiotic regimen. And if you looked at those 7 patients, what we noticed were all were male, 6 of them were adults, and all the adults were greater than 90 kilograms in weight, and all of them received rifampicin and clarithromycin as their antibiotic regimen. Now, as we've discussed earlier today, the recommendation for rifampicin is 10 milligram per kilogram. Okay, but if you look at if you've got people with this weight range, if you look at their actual milligram per kilogram, you can see it's really low, and the average for rifampicin was 5.6 in these patients, or half of the recommended dose. And if you look at clarithromycin, it was similar, 8.1 or 54% of the recommended dose. Bearing in mind that what does rifampicin do? It reduces the clarithromycin dose by up to 90%. So if you've got 90% of this, you've really got minimal clarithromycin hanging around at all. So the concern just looking at this is that maybe there's an issue with our antibiotic dosing in people over 90 kilograms, especially if they're male, and maybe the regimen's got something to do with it as well. So we looked at that only on univariate analysis, and we couldn't do multivariate analysis because there were no failures outside of these groups, unfortunately. But if you look at the univariate analysis, highly associated with weight, greater than 90 kilograms, and that persisted even if you had stratified that for gender. For males, it was also significant. Immune suppressed, which is not surprising, and the rifampicin clarithromycin regimen also came out as significant. So once again, back to the males, what we have seen in TB studies is that once again the level of rifampicin in males is significantly lower than in females. So it may also relate, therefore, to the actual gender specifically, that we're not only are we underdosing the rifampicin, but especially in males that we're underdosing the rifampicin. So what has never been done, but clearly needs to be done, and hopefully we can get done with Andrew and Jason, is to do some pharmacokinetic and PK and PD studies looking at this. Because what I do wonder is whether in males, especially more than 90 kilograms, we should be using high-dose rifampicin. You know, maybe we should be using 900 to 1,200 milligrams per day. But also maybe we should be using slightly different regimens. Fluoroquinolones aren't reduced significantly by rifampicin, and therefore maybe they're a more suitable regimen to be used in selected cases such as males more than 90 kilograms. But I think the most important thing is to at least get some background data, because in those studies we looked at, we haven't got any data to say that the clinical failure rate actually does correspond to low antibiotic levels. I'm just going to say one other thing. The other thing with antibioticity is that sometimes you don't need to treat, actually. We've had now 15 patients that spontaneously healed just through observation. And the bottom line is if you get small lesions in people who've had the disease for quite a long time, so it suggests the immune system has some control over the organism, and because they're small, they're not going to take off if you keep them under close observation. So the median size of these lesions is about 160 millimetres, I think, and they're ulcerative, that in fact they can heal without any treatment at all. And I think that's a real benefit to patients because of the antibiotic toxicity. They're not easy to take. So that is another option that is available to clinicians nowadays if you've got closely supervised patients. Okay, I'm going to stop there. That's just the beach.
It's great to have such an energetic speaker for our last speaker. That was very good. Thanks, Dan. So, Christian there.
Look, yeah, I do extend in people that I've been treating with steroids who've got very severe lesions. I might extend to 10 weeks or a maximum 12 weeks. Now, that's purely just a gut feeling. There's no evidence behind that. In fact, mouse studies show if you use steroids that you don't need to prolong your antibiotic treatment. But when you've got a big lesion that's doing really badly, you just feel a little bit nervous stopping at the 8 weeks. So that's the only situation I do it. Most of the time I think we overtreat, but there are some situations. And I think now, having learnt this just in the next few days, last few weeks, is I think we really need to look at heavier patients, especially males, and think a little bit more about what we're doing in that situation.
This is a question to Andrew and Dan. If we go into a PK study in this population, how often do we have to sample the patients?
So I guess for some people, look at you've got intensive PK sampling, where people do hourly blood tests for 8 to 10 hours, which is hard to impossible, not impossible, very hard. Then you've got limited sampling strategies, and so a lot of Dutch groups have done looking at 3 samples over about 4 to 6 hours. So maybe 3 separate samples might give us some information, getting an air under the curve. So that might give us a bit of a signal there. Jason, do you have any comments on that?
Just that it might be worthwhile possibly repeat it a month later or something like that in case there's any enzyme reduction or anything like that if you want to try and describe as well.
So I mentioned to Dan that rifampicin has this process of auto-induction. So after about 8 weeks, you've got about a 30% less level than you do at the start. So that's another thing to think about, which complicates things a bit.
Can I ask, with respect to the Queensland strains, is there any clinical differences of how the lesions behave, given that there might be some differences genetically?
Look, I can't really comment. I've never looked after any Queensland patients. I mean, historically they've done a lot more surgery than we have, they haven't treated as much with the antibiotics, probably, at least until recently anyway. So I suspect they behave very similarly, but I couldn't say for sure whether there is any slight differences.
Is it the same number of severe cases? The ratio roughly the same in North Queensland versus?
Yeah, I'm not sure actually.
It's notifiable and there's a case report form that's something similar to the Victorian one. So we can look at disease severity. It's not necessarily longitudinal surveillance to get treatment outcomes.
I would say in Africa, I think they behave quite similarly, except that they don't seem to see as much paradoxical reaction as we do. Maybe that's because paradoxical reactions are increased in elderly. The older you get, you have a higher rate of it. Or maybe they don't measure it as closely as we do, I'm not sure. But they do seem to see less of that. The other difference that they have is they don't have the antibiotic toxicity that we have, because our median age is 57, whereas their median age is something like 12 in most of their cohorts. So in the more elderly people, you have a higher risk of antibiotic complications. So it's slightly different, but I imagine Queensland's probably quite similar.
Well, thanks very much everyone for your attendance. It's been a long day, but I've really enjoyed it. I learned a lot from all the speakers. So thanks very much for coming, and enjoy the rest of the evening. And thanks to all our speakers who have travelled. Some have travelled from Vietnam, such as you, Joe, and others have travelled from the States. So thanks very much.
Yeah, no, we should say we'll walk on.
This thing, I think about how we do it.
Yeah.
And we're good. I've got some thoughts already, so maybe next few weeks. Okay?
So you're heading off to dinner now, are you?
Yeah, we'll go for a drink and just a convention set up. And